Hello, everybody, and welcome back from the break. We are excited to have our final speaker here today. I'm going to introduce Kelly Russell, or Dr. Kelly Russell, who's going to come and moderate this session.
Thanks, Carrie. So I'm here to introduce our last speaker of the day. In the panel earlier today, Dr. Ezopenko asked the panelists for input on how to break down silos and work with communities. So it's great that we are able to have our last talk that really is addressing that exact issue. So I'm pleased to introduce Dr. Caroline Piotrowski. She is an associate professor in the Department of Community Health Sciences and a scientist at Children's Hospital Research Institute of Manitoba. Her background includes developmental psychology, lifespan human development, and health promotion. Her areas of expertise include the effects of exposure of intimate partner violence on children, trauma and resilience in young people and their families, post-traumatic growth, and sibling relationships. She is particularly interested in how the social determinants of health interact with family factors to influence risk and protective factors for violence and injury. She is currently leading an international multidisciplinary team that's evaluating an intervention for Indigenous mothers and children affected by intimate partner violence in Canada. So I will hand it over to Caroline for her talk entitled Learning to Walk Together on Our Healing Journey, the Development and Evaluation of a Culturally Sensitive Intervention for Indigenous Mothers and Children in Canada who have experienced intimate partner violence.
Thanks very much for that great introduction, Kelly, and also for managing that excruciatingly long title of my talk today. I appreciate that. And I'm just going to start sharing my screen, hopefully, so that it works. And just want to make sure everyone can see it and everything is working okay.
Looks great.
Fantastic. Then because Kelly has already read my super long title, I'm just going to get into what I'm talking about today. So I have started working on this particular project quite a while ago now, but we're well into it despite COVID. But before I get into the details of how we managed to organize this multi-site project, I do want to begin with a traditional territories acknowledgement. So I am located at the University of Manitoba in Winnipeg, in Manitoba, in Canada, as Kelly mentioned. And my university is located on the original territories and homeland. It's called Treaty 1 in Canada, the lands of the Anishinaabe, the Cree, the Oji-Cree, the Dakota, and the Dene peoples, as well as the homeland of the Red River Métis Nation. And so we respect the treaties that were made on these territories. We acknowledge the harms and the mistakes, not only of the past, but also ongoing in the present. And we dedicate ourselves to move forward in partnership with Indigenous communities in a spirit of reconciliation and collaboration. And this particular project is very much done in that spirit of reconciliation, as I hope it becomes apparent to all of you who are listening here today. So I'm sure the stats concerning IPV have been well covered and well discussed by various people before me. So I'm just going to briefly touch on the situation in Canada and specifically with Indigenous women and children in Canada. We all know it's a very serious societal concern. We all know that IPV rates vary tremendously, not only from country to country, but also based on the type of data that's collected, whether you're relying on survivor reports or medical records or police records, or, it really varies a lot. And so the incidence and prevalence that we report is almost always an underestimate of what is actually going on out there. One example of a database in Canada is police records from not too long ago, indicating an enormous number of documented cases of IPV against women in Canada. And these are only ones that made it to police reports. And we all know that the cost of IPV is extremely high. First of all, for those who experience it, of course, but then also for all the rest of us, not only in terms of the medical and mental health services that are required to deal with the aftermath of IPV, but of course, the toll that it takes on people's lives moving forward. So the focus of my talk here today is on my team's work with Indigenous women in Canada. And I'll just start with a very quick explanation of terminology. So in Canada, the term Indigenous actually refers to three main groups: First Nations, who are various tribes who've lived in Canada for thousands of years, of course, the Inuit who live in Canada's far north, and the Métis population, which is somewhat, I think, unique in comparison to the United States Indigenous population. The Métis population, their history is based on the early integration of French culture and the existing First Nations culture at the time, and it has since evolved into its own unique and distinct history and identity. So when we think about Indigenous peoples in Canada, that includes all of these groups. The inequities among Indigenous women really need to be understood within the historical context of Canada. So rates of IPV are much, much higher for Indigenous women than non-Indigenous women in Canada. And that has to be understood within the context of colonization and the intergenerational effects of all of the collective traumas experienced, not only by previous generations of families and communities, but also current ones as well. So we know well the negative impacts of IPV for women and for their children. That's been well documented. We know that they're at elevated risk for a wide variety of physical, mental health problems, not only in the short term, but also over the life course. So what do we do about it? And how do we go about working with groups that are disproportionately affected, such as Indigenous communities in Canada? Well, there are very much effective interventions around that help to reduce the suffering of mothers and children in the short term, but they have also been shown to break the cycle of violence in the long term. And we really need to bring these forward for Indigenous communities in Canada. Unfortunately, there are very few evidence-based such programs for these populations at the moment. So when we started thinking about what we were going to do, of course, we started with a review to see what was going on. Is there anything out there? Is there anything published? We did find just one other Canadian intervention. However, it was focusing on the needs of female survivors of childhood sexual abuse. So specifically, Indigenous women who were survivors of CSA, rather than women who'd experienced IPV. So it was something that we felt the urgent need to do something more about. And this, of course, has been urgently requested by Indigenous groups, both formally and informally, for a long time now. So one report by the National Aboriginal Circle Against Family Violence reported that the general lack of culturally appropriate programming is a big concern, as well as a dire need for more children's programming. And so if you simply go ahead and use a program that has been designed elsewhere for other groups, for other women, it might not have the same impact is the first concern. But the second concern is that if it is implemented without the proper cultural context and adaptations, it can cause unintended harm. It can inadvertently exacerbate existing traumas and continue the histories of Canadian colonialism and health inequity among Indigenous populations. So this is our challenge. It is not a small challenge. We certainly don't take it lightly. And so we have invested a lot of time and a lot of energy in the preparation of what it is we want to do. So our version of the NIH, the CIHR, the Canadian Institutes of Health Research, does fund mental health and other health interventions. So we organized an interdisciplinary team and received funding from this federal agency. And it very much is not only multidisciplinary and interdisciplinary in terms of the researchers who are involved, but we very much involved community. And these are the elders, the knowledge keepers, and the agency staff of the agencies where this intervention will be implemented. All of them are stakeholders in helping us to create and adapt the program that we want to deliver. So we're in this process now of conducting a feasibility study of an evidence-based intervention, and we are designing it specifically to meet the needs of Indigenous moms and their children who've experienced IPV. So our first step is to find an existing evidence-based intervention and then adapt it and then see what happens. So what intervention did we choose and why did we choose it? Well, we decided to go with probably one of the best known and regarded, at least in the research literature, interventions for moms and children who've experienced IPV. This is the Moms Empowerment Program and Kids Club Program, created and designed by Dr. Sandra Graham Berman at the University of Michigan, and she is a co-investigator on our team. And basically, it's 2 programs, 2 10-week programs, of course, trauma-informed, that are delivered simultaneously but separately to mothers and their children. So mothers are in one group, their children are next door in a room with other kids, and each week they come together and experience the program and move through a series. And you can't really call it curriculum, but definitely it's guided group discussions that very much address the heart of the effects of IPV. So why did we choose this particular program? Well, because it has been shown to be extremely effective. Sandy found that when both the child and the mother participated in the intervention, the child showed the greatest improvement over time when compared with children who participated without their mothers. So she did compare a group of children who received the program to a group of children who received the program with their mothers to those who did not, and found fairly impressive reductions in what we typically see in terms of child externalizing behaviors, as well as child internalizing behaviors. And these are the 2 classic ways that children express the symptoms typically. She's done other work that has addressed post-traumatic stress symptoms and PTSD, not only in the kids, but also in the mothers themselves. She's also looked in other studies at depressive symptoms and anxiety symptoms. So I'm just focusing on one RCT that looked mostly at the outcomes for kids, and again found a very significant reduction in internalizing behaviors when both moms and kids received the programs as compared to when only kids received it, or as compared to a waitlist group. And then this is not only done immediately following the delivery of the program, but then she also did a follow-up several months later and found that these reductions in symptoms persisted over time. So a graphic depiction shows us here that when it was both the mother and the child who were participating in these programs together, there was the most significant reduction in symptoms. When it was the kids only versus a waitlist control group, there was far less reduction. So we knew that this was shown to be very effective in the groups that Sandy originally developed it for. So she's in Michigan. Many of the groups were located in Michigan. She's also delivered this program now internationally, many different locations and sites, and not only in the United States, but around the world. And we wanted to deliver this program here in Winnipeg, but we have 2 sites that are involved in this study, and the other site is in Calgary, Alberta. So we started our process by assembling a community advisory council. So we found agencies both here and in Calgary who worked with Indigenous moms and children who said, yes, we're really interested in learning about this program and delivering it to the moms and children that seek our services. So those staff members were participating. We had elders from both Manitoba and Alberta. Of course, Dr. Graham Berman, who created the intervention, was part of our group, and some other researchers from both the University of Manitoba, the University of Winnipeg, the University of Calgary, all got together to do this. So we are using what is called a two-eyed seeing approach, which was actually a term developed by Mi'kmaq elders in Canada who were collaborating with researchers. And the idea here is that the contributions of Indigenous knowledge, Indigenous ways of knowing and being are combined with and considered equal to Western ways of knowing and being, and that we work together in a complementary fashion because each knowledge base has its strengths and each provides a different source of healing and recovery for the mothers and children. And they're seen as different but equal. And so there's very much a respectful balance between bringing together experts, both Indigenous and non-Indigenous in our groups. So this is considered to be a transformative approach where we very much emphasize the cultural strengths of the Indigenous community, local Indigenous knowledge, and any positive aspects of the community that can be infused into the existing curriculum of the Moms Empowerment and Kids Club programs. And so we started this adaptation process, but we did have some guidelines in place. We were following what are known as the 4 R's in collaborative research between Indigenous communities and university researchers. And those 4 R's are respect, relevance, reciprocity, and responsibility. We also have what are known as OCAP principles in Canada. Any work, research work based at a university needs to know and understand and adhere to OCAP principles. And I'm not going to get into a lengthy explanation of them, but basically they give researchers guidelines, very specific details about the approach and where the data belongs, who owns the data, how to gather and collect the data respectfully, how to make sure that all who contribute to the research process are acknowledged and have a say as to how the data are used and how they are shared. And we also looked at frameworks of previously successful collaborations that emphasize meaningful engagement, shared decision-making, and honoring the preferences of our community advisory council partners. So for example, if the elders wish to begin our meetings with a prayer, and they wish us to respect the wisdom that they're going to share with us by offering them a traditional gift of tobacco, then these are things that are incorporated into the adaptation process. So our goal was not only to incorporate authentic and meaningful Indigenous ways of knowing from both locations. So I'm Winnipeg, I'm Treaty 1, Calgary, Alberta is Treaty 7, but also to make sure that we were adhering to the public health principles of flexible, culturally tailored interventions. So a well-known researcher from Saskatchewan, Dr. Marie Baptiste, reminded us before we even got started that there's no such thing as a single set of Indigenous principles or knowledge or wisdom. Of course, there's variability. There are differences between ordinary folks, such as the agency staff who are participating in our adaptation process, and experienced knowledge keepers and healers, and elders and ceremonialists. So there's going to be heterogeneity, there's going to be differences of opinion. It's dynamic, it's evolving. And so this heterogeneity needs to be incorporated in the work that we're doing and respected. And we need to make sure that we are sensitive to that. So as I mentioned, I'm Treaty 1. Treaty 7 territory has a different group of First Nations on it. So it is the traditional homeland of the Blackfoot Confederacy, as well as the Naroda and Tsuna nations, and also has a Métis population as well. So we needed in our adaptation to be aware of that and to make sure that in each location, when the intervention was delivered in Calgary, that it was incorporating local knowledge there. When it wasn't delivered in Winnipeg, that it's incorporating local knowledge here. So we had an agency called Discovery House in Calgary. And so various members of the Discovery House team participated in our adaptation process, as did local elders. Similarly, here in Winnipeg, we had a local agency, the staff members there, as well as a local elder and Indigenous consultants. And then, of course, we had our research team. Fundamentally important was Dr. Graham Berman, but then, of course, other members of the team who brought various areas of expertise and knowledge to this adaptation process. So that's a lot of people, that's a lot of voices, that's a lot of information. So we started back in fall of 2019 with a series of 7 team meetings. And following those 7 meetings, we felt we started to have an idea of how things were gelling. We held a training meeting with staff from both agencies, and we were just about to launch our pilot when a little thing called the COVID-19 pandemic began. And so, of course, our project was paused as it needed to be. During the pandemic, not too surprisingly, as many agencies did, both of our agencies experienced major staff turnover. And so we needed to reorganize once things started being put back into place. So that started happening last fall. There was new agency leadership and staff. We now had a new elder who joined the team in Calgary, who was working closely with Discovery House. So this meant that we had to revisit and continue our adaptation process, working with the new staff, reviewing the materials, the revision of the curriculum and the Moms Empowerment and Kids Club manuals. And that was all done in close collaboration with the new elder who is now part of our team in Calgary. So the core of what I wanted to share with you today is, how did this adaptation process go? What lessons did we learn? And how can we foster the same kind of approach in other researchers who might be interested in following this kind of culturally sensitive adaptation to interventions that they know would be effective for different specific cultural groups. So we talked to those involved. It's an ongoing process. We've talked to some agency staff, to researchers, to the elders involved, and I'm here to share some of the lessons that we've learned. One of the first ones, and one of the primary ones, is the importance of authenticity and integrity of local knowledge. So we began our journey, as it is known in Indigenous culture, in a good way, by including as many local partners, elders and knowledge keeper and agency staff from each location, as many as wanted to participate. The elder that has more recently joined our project from Calgary is unique in that she grew up in Winnipeg, and so she actually identifies as being part of the Cree Nation, but she now lives in Calgary in Alberta and has a longtime partner who identifies as part of the Blackfoot Nation. So she's a wonderful makes wonderful contributions to our project because she has an intimate knowledge of ways of knowing and being from both treaty territories. And so she can very much contribute subtle nuances of what is the same, what is different. No, these stories are not Treaty 7. These stories are not applicable for the population in Calgary. They're more Treaty 1. And so it's very much those subtle nuances of her intimate local knowledge that we really appreciate. So she's bringing, the local identity, some aspects of language, of course, some aspects of culture, but mostly the history of what has happened to Indigenous peoples in Canada. So we're trying as much as we can to avoid pan-Indigenous knowledge in our staff training and manuals. There is a lot of heterogeneity, and we need to be aware of that, and we need to respect that. And one of the researchers really talked about her learning curve. So she mentioned, I had, a little bit of knowledge, but all of those conversations, all of those meetings that we had, kept enlightening me. I feel like I learned a great deal, and I probably made some missteps, but I felt welcomed. I felt like the people involved, meaning the agency staff and the elders and the knowledge keepers, were taking a big chance on us to work with people who are precious and who are suffering. But they were open to saying things to us. They were open to correcting us and saying, well, there just isn't one nation here. And so some things are very similar in terms of the background of various Indigenous groups, and some things are quite different. And another important lesson that has really come to the fore, although we were very much aware of it as we were starting, I think we have become even more deeply aware and wanted to make sure that everyone who knows about the project understands that we come to it with a sense of duty and a sense of responsibility. And so for all of us involved, the learning about this adaptation process, this infusing of Indigenous ways of knowing and being, was not only about the facts of what has happened and what is happening to Indigenous people in Canada. So, for example, the Indian Act, the residential school system, the 60s scoop, all of these discriminatory policies that the Canadian government created and followed for many, many years, It was also about expressing acceptance of that history, validating the legacy of the trauma of that history, and expressing a willingness to find a way forward, given that context, understanding that context. And so this is a quote from one of the elders who was participating in our process. What it needs to be is, this is real. It actually happened. This is who it happened to. This is how it happened. And this is what we can do about it. You know, all of us have a duty and a responsibility. So it's very much a team-oriented approach where those who were less aware became more aware and relied upon the wisdom and the perspective of those who had intimate knowledge from their own lived experience. And the third and final lesson that I'll share today, given that my time is nearly done, is that there's a fine line. So knowing more about Indigenous culture, we are hoping will provide a sense of pride, a sense of resilience for mothers who've never ever been exposed to it before. So we're not assuming that the mothers and children who identify as Indigenous that come into the program will have an intimate knowledge of their background and their history and their cultural identity. We don't assume that at all. We don't require it at all. So we're hoping that this infusion of knowledge will help with imbuing a stronger sense of pride and resilience for them, even more so because it is infused within the intervention concerning IPV. But as we were cautioned, there is a fine line between what can be put into the intervention curriculum, things that can be practiced, such as I mentioned, starting in a good way with a prayer or with a smudge, which is an Indigenous ceremony of purification that usually begins an activity of importance. But there are things that must not be included, not sacred knowledge. And so the quote from the elder was, we don't take those things for granted. Sacred knowledge, such as certain ceremonies, we can't just throw them in and introduce them casually and say, oh yeah, no, we'll just pop into a sweat, referring to a sweat lodge ceremony, which is a sacred ceremony. So this is where the guidance and the wisdom of our elders and knowledge keepers and the agency staff who identify as Indigenous, who also have a tremendous amount of knowledge, is really, really important. And their contributions allow us to understand that certain things should not be referred to in this infusion of a cultural knowledge into the adaptation. It might exploit what is sacred. And if you throw something in when people are not ready, then it's not really of value to them, and they don't really benefit from it because they don't really understand the deeper meaning of where it comes from. And they don't yet know enough about their cultural identity and background to really find it fully relevant and meaningful for them. So I'll just let you know that we are now finally ready, we think, to proceed. We're going to be doing our pilot in January at our agency in Calgary. And as we unfold that 10-week program, we are going to be collecting the perspectives of the participants, the moms and children who are in the pilot program, as well as the agency staff, those who participated in the adaptation and the implementation, as well as our elder in Calgary. We're going to be using a mixed methods approach to better understand how is this being received, what are the strengths, what are the weaknesses, what needs to be tweaked, what needs to be enhanced and maintained. And of course, we plan to expand the program once the pilot is complete. And we're very excited to see where the next steps of our journey lead us. So thank you so much for your attention today. And I'm happy to take any questions that you might have.
Thank you so much, Dr. Piotrowski, for that lesson, or sorry, that presentation. There were so many great lessons in how to work in a good way with communities that have undergone so much trauma that we and our collective history are responsible for. So thank you for that. There is one question in the chat that we can start with. So it is asking, for families where grandmothers or grandmother figures or aunts is the caregiver of the child or children, is there issues prevalent in your communities? And if so, how is it customized if the mother is not present for the mom and baby program?
Well, we are going to recruit anyone who is a caregiver of the children. So if you are the biological mother of the children and you want to participate in this program, you're welcome. If you're the auntie, if you're the grandmother, kukam as the Indigenous term is used, doesn't matter, you are welcome. And so there's no set definition of what makes a family admissible. The criterion are wide open. And to that extent, we even include and welcome families who don't identify as Indigenous, as long as they understand that, this is what the program is going to be about. And you're going to be hearing an awful lot about Indigenous identity and history, but we're not going to kick you out if you're not. And so it is really the spirit of inclusion and acceptance that is really, really key. And Sandy's program is set up so that anyone that has experienced either directly experienced IPV from a partner or has witnessed their daughter, their sister, their mother, whoever, as an adult, they are also welcome. As long as they're a caregiver of the children, they're welcome to participate. So we're trying as much as we can to be, because we know from the agency staff that we need to be inclusive in order to make the program accessible and make it work.
Thank you. I was curious how much your intervention, or what you thought was going to be your intervention, changed from the time you actually wrote the grant to then having, I think you said 9 meetings, how that kind of evolved and changed, and how, from, I guess, a bit of a grantsman perspective, you were able to secure funding knowing that, kind of what you probably wrote as your intervention isn't necessarily what it looks like today.
It's a great question. And so because we started with Sandy's standardized intervention, right? So she'd manualized it, she'd repeated it in different cohorts with different groups with different backgrounds. We knew that part of the content was going to change, but those pieces of the intervention that have been shown to reduce that symptomatology are still there. It is an addition to that that we didn't know exactly what would be added. So none of the essential pieces have been removed, but a lot of things are now there that we, as Western researchers, we wouldn't have imagined. So a Google search of, what is Indigenous knowledge and what are the 7 sacred animals, for example, in Cree culture, you can do as a Western researcher. Doesn't mean that adding that quote information is going to be culturally relevant or meaningful in any way for the mothers. It really takes the Indigenous community to participate and infuse that in a way that is meaningful and relevant. And so, for example, the sessions where the history of the residential school system and the legacy of traumatic policies are discussed is one of the sessions where an elder is there in person and talks about that. And although we knew that should be referred to, the style of how that is done and the meaning of who that is, who delivers that message, can only be done by our Indigenous partners. So it is a challenge to give up a fair amount of control, and to know that some pieces of the intervention will be delivered as it has always been done, and some pieces are just going to evolve and change over time. And just documenting that and tracing that and making sure that we can share that evolution with other researchers and community agencies so that they can benefit is our main goal. But it's an interesting process.
Thank you very much. There's one question in the chat. I'm not sure if the person anticipated it for this speaker, but we'll get your thoughts on it anyhow. So several of the speakers today have been invited to speak in New Zealand in March 2024, and we're being welcomed in a welcome ceremony by the local people. I was wondering your advice to us to go into another culture to speak about IPV and TBI.
Yeah, that sounds amazing. And just before the pandemic struck, I actually visited New Zealand in Australia. So what a treat. I'm so happy to hear that you're going. I think the lessons that we learned was to go in as a respectful learner, and to express not only appreciation and respect for the knowledge that is shared, but to be particularly sensitive to the validating of the cumulative history of experience is really, really important. And I think that we had a sense of that a little bit when we started our collaboration. But like any group that has experienced serious collective trauma, serious intergenerational trauma, ongoing discrimination at a systemic level as well as an individual level. And unfortunately, that fits many different cultural identities today, I'm sad to say. Being particularly expressive of the validation of that history and the collective toll that it takes is really, really important. And it needs to be heard. It continues to need to be heard. And I think it will need to be heard for a long time. And that is the spirit of reconciliation, is making sure that those who have suffered and are suffering know that their suffering is seen and their suffering is acknowledged. It's very important.
Thank you. I'm curious what biggest misconception you had originally going into this project that was then burst or
exploded.
I don't know what the right word is, but exploded sounds like this is going to be a great answer.
Yeah, well, I kind of like things to be neat and tidy. You know, I like to set things up so that in session A, X happens, and in session B, this happens, and in session C, that happens. And we know exactly what will be discussed and how long and what the topic is. And it's very neat and tidy and organized. And no, just no. Just no, that's not going to happen. And being flexible enough to accept that, especially with issues like collective trauma, history and intergenerational trauma, and ongoing systemic discrimination, it's just going to keep coming up. It's going to come up repeatedly. It's going to come in waves. It's going to ebb and flow. So when it comes up, it can't be shut down, because this is session 4. And we talked about that in session 2. So we're not talking about that again. Like that's not going to work. So it has to be organic. And the weaving and infusing of these perspectives and this knowledge has to allow for that. And the agency staff members who are identify as Indigenous, the knowledge keepers, the elders, they all knew that. Like, to them, that was just intuitively obvious. And they were a little surprised that, why are you being so rigid? And and it took me a while to realize, yeah, that is being rigid. And it does need to be discussed and come up in a way that's relevant for the topic at hand and the actual session that's ongoing. So once I wrapped my mind around that, all is well.
So really highlighting the importance of relationship building, and
it's all
how that's come up repeatedly over the last couple of days.
It's all relational, basically. And without the very impressive courage of those we have worked with to trust and to build a relationship, it just wouldn't fly. We could go in with a Western-based intervention, and if anyone showed up, and not saying they wouldn't, they might not. But if they did, I think it would be far less meaningful and relevant. And I'm really hoping that our pilot and our subsequent implementation shows that. So we'll see.
Well, I hope in a couple of years' time we can invite you back and get an update of your results. That wraps up the formal part of our speaker part of this program. So I will now pass it back to Carrie Azopenko for a wrap up. Thank you.
Thanks, everyone.
Wow, thank you so much. That was such a fantastic talk. Just going to quickly put up a slide here. So we're just wrapping up. We did want to make a quick announcement that the next Global Knowledge Exchange Network meeting will be November 29th. It will be an education session featuring Doctors Michelle Patch and Jackie Campbell, where they'll be talking about strangulation-related injuries. If you want to join that, please send an email to the link below there, or to the email address below. Next slide. And with that, we would like to say a profound thanks to everybody for being here. We had a total of 480 registrants across the world. So not everybody could be on at the same time, but we will be recording, or we will be putting the recordings on the ENIGMA website. It'll take roughly a week for us to be able to get them put up there. I wanted to give a huge thank you to our speakers and panelists for putting together absolutely incredible, fantastic talks. I feel like I'm going to be unpacking all of this information for a very long time. I'd also really like to thank the conference organizers, the conference organizing committee, and particularly Katie, Divya, and Sophia for running all of the behind the scenes thing here. We ran on time. We had very little technical issues, and I'm so grateful for that. And we're hoping that you can do the post-conference questionnaire or survey. It's a feedback survey. It'll help us make plans for next year. It'll help us know what was good, what you didn't enjoy as much. If there's any way we can improve the accessibility of this, we'd be greatly appreciative. And thank you to all of you for joining. The fact that we had a talk 4 o'clock on the Thursday and there was over 100 people on this, still, we're so grateful. So thank you all so much. I hope you have a great rest of your week. And again, we're just so grateful that you all joined. So thank you.